Brilliant. So it's really good to be with all of you tonight, all your peers on the webinar that's just finished probably a hard day's work in either community hospital or primary care. Let's go and explore how we can continue to fill these gaps that we've been filling right from when the first lockdown was declared, even until right now, because we're still fighting COVID-19. So this is my team and this is Carolyn's team. Loads of great times here, as many of you have great times in your teams. Carolyn, what are you dressed as here?
That I think I'm a clown. I'm in the back.
Yeah, that's so awesome. Love the culture there. So yeah,
we celebrate everything. We had scones the other week. Yes, harvest hump days every Wednesday.
Love it. So I'm a community pharmacist. Carolyn's a specialty pharmacist, and we're friends and peers, and we share a lot of stuff amongst each other. So we're going to share some stuff with you. These are some of our disclosures, and we'd really like to start by thanking OPA and Pfizer for supporting this event. This is Carolyn getting her booster last December. Very, very good times. Fun fact, she refused to believe the needle went in. So there you go.
You were awesome.
So today, Carolyn and I, what we're going to do, we're going to use real-life clinical vignettes to explore opportunities to optimize protection against vaccine-preventable disease in diverse patient populations. We are going to discuss the role of pharmacy professionals in collaboration with primary care teams in the patient-centered approach to the prevention of vaccine-preventable disease. And we're going to discuss the evolving role of antivirals in the treatment of COVID-19. We're not going to be didactic, we're not going to be hypothetical. We're going to go through 4 of our real-life vignettes and share best practices amongst each other. There you go, Carolyn.
So when we think about what patients generally, what do Canadian adults think about how much they've been vaccinated versus what is true? And so when you ask people, and this was an older survey, 2016, but 88% believe they were up to date. Now that is based on, we're looking at their risk of age, their conditions. 88% said, yeah, I'm up to date, where in reality, it was only 3%. So that's really an upsetting statistic, because when we ask that question, are you up to date, really tells us it doesn't hold a lot of weight. In the next slide here that Siva is showing, we did also a follow-up, and this is really interesting. So OBRI, if you haven't heard of it, is the Ontario Best Practices Research Initiative. And basically, rheumatologists across the province ask their patients if they're interested in being part of this registry. So this registry has, many people that we are calling on an every 6-month basis to get really a sense, so over 500 patients, as to how they're doing, how their treatment's working. And so I work with this group, and one of the things I had suggested is, why don't we ask about their vaccination status? And so we started asking this back in February of 21, and the report was just given last month at the annual sort of update. And so this is data up till April of 2022, and you'll see that in the larger or the darker pink bar, if you will, on the left. But that was the rate reported by patients who are at risk, who have an autoimmune condition, who ideally should be recommended vaccination, not just by their family physician, but by their specialist and hopefully by their pharmacist. Then in the pink, you are seeing a smaller group. So this is close to 198 patients actually in Kingston, Ontario, also in a rheumatology practice, asked about their vaccination. So this is self-reported vaccines and what they've had. What it tells us, we are far under where we need to be. The goal for NACI, our National Advisory Committee on Immunization, wants 80%, especially in those over 65 for influenza and also pneumonia. But keep in mind, those are at risk, often have a greater risk at a younger age than even the 65-year-old. So just sort of puts in perspective current data and the gap we need to fill.
Yeah, you know what? It just shows us that we've got lots of work to do. And you and I were talking earlier about how we've evolved, right? So we've all innovated, we've all evolved our practices so much that we, the public, and even the government, they realize what our capacity is and what we deliver to our healthcare system. So many of us, we've established a pharmacy technician vaccine champion. It's a necessity in so many practice settings, just because the volume of interactions required by us in helping us realize what we're able to achieve. We've fortunately and unfortunately had greater exposure and increased experience with incidences of fainting, anaphylaxis, along with rarer complications like lymphadenopathy. We'd never seen this before, but we've seen a lot more of it recently just because of the volume. We have, as a profession, being really the go-to place for vaccinations, shared with patients the value of vaccination as a means to prevent hospitalization and death, rather than just infection, which can now help us explain these as desired outcomes for other vaccines such as influenza and pneumococcal disease. So this is the time to reflect and how we're going to capitalize on how what we've learned is going to be utilized in this upcoming flu season that now has COVID added to it. So we're going to start with your patient, right, Caroline? A real
Absolutely.
Person that you see.
So this is Sandra, 52 years of age, diagnosed with seropositive RA, so either rheumatoid factor or anti-CCP would be shown in the blood work, and that diagnosis happened at age 50. So as we normally would do, we want to get people on those disease-modifying treatments, DMARDs, right away, and the conventional synthetic ones, such as methotrexate, hydroxychloroquine, and sulfasalazine, were used in combination. She still had 10 swollen and 8 tender joints. So that actually made her approved from both a government funding and private payer perspective to move to an advanced therapy. So she started an anti-TNF therapy, a biologic, adalimumab, many of you know as Humira, and now we have 8 biosimilars in that group as well. And she was given this for over 3 months, the amount of time we would expect to need to really assess its benefit. You know what, it just didn't do it. So today she comes to her community pharmacist indicating that her rheumatologist has prescribed the infused medication rituximab. You may be familiar with this in cancer settings. R-CHOP, one of the B-cell lymphoma therapies, includes rituximab. So not dispensed in community pharmacy, but one that you're aware of. So we give this commonly in rheumatoid arthritis, vasculitis, other rheumatic conditions, and it's going to be booked in the next 4 to 6 months. So in looking at her sort of medications and vaccine history, we can see, yes, people with rheumatoid arthritis do have higher cardiovascular disease than the general public. She is on a statin and ramipril for blood pressure. She's still taking methotrexate as an anchor drug, which we commonly do. We add on to methotrexate. We don't usually replace it. Folic acid, of course, is in combination. And the adalimumab will be continued until she's transitioned to that rituximab. So probably about 2 weeks or so before that IV is booked, we will stop that every 2-week treatment. So we have a little window here in terms of vaccinations. What happens with rituximab is it is a biologic, it's a protein, and it's attaching to a certain B cell in the immune system. We call it a CD20 B cell. When rituximab attaches to the B cell, it causes it to lyse open. It breaks it apart and it flushes it out. Those B cells made by our bone marrow, when they are flushed out, they are our antibody factory. So we really lost the ability after a rituximab dose to have a good B cell response, a good antibody response to vaccines. So here we have this window of opportunity for this woman to update vaccinations she may not have already had before getting her rituximab dose. And this is the key window when you want these things done. To be honest with you, Siva, the key window would have been when she was diagnosed before she even started methotrexate. Everything should have been up to date. But it doesn't always happen that way, and sometimes we have to play catch up. So these drugs that deplete B cells, such as rituximab, it's really key to get vaccination in ahead. We notice here she had influenza 2020, but she didn't get one last year in 2021. Not everyone took advantage of that, so we'd want to get that in before she starts. Pneumococcal vaccination, she had Pneumovax. Geez, Pneumovax is a conjugate vaccine. Doesn't work as well, Pneumovax, sorry, a polysaccharide or sugar-coated vaccine. Doesn't work as well as our conjugate vaccine, Prevnar. And honestly, a couple of years ago, 50 and over, she would have been a candidate free of charge from physician supply to get Prevnar 13. She did not. She only got Pneumovax. So that was unfortunate. So we want to talk about that. Tetanus 12 years ago, gee, you need that every 10. That one's up to date. Twinrix, never need to repeat. And she got all her 3 doses in prep for a holiday. So that's her status. What are one of the places, and you'll see on the next slide, one of the places that I look to find out the most up-to-date information, often before NACI has a chance to make their statement or the Canadian Rheumatology Association, we look to the American College of Rheumatology, or ACR, for guidance in this population of patients with rheumatic diseases who are often on treatments that will suppress their immune response. So here's the guidance that was updated in 2022 in February. And what it tells us is for patients with rheumatic and musculoskeletal diseases, they're saying RMD, age 65 and over and greater than 18 and less than 65, so really everyone over 18, who are on immunosuppressive medications giving a high dose or adjuvanted influenza vaccination is conditionally recommended over the regular dose. And we saw that out of a study from actually Montreal, and that was at McGill, that yes, we know our rheumatic disease patients, people on immunosuppressive treatments, would be better off and would have a higher antibody response, regardless of what treatments they're on, would have a better response if they had a high dose influenza shot. And they would probably be in more need than a healthy 65-year-old. Yet, unfortunately, our high dose vaccination for influenza, certainly in the province of Ontario, was only allocated to those over 65. I'd love to see that change in the future. For patients with RMD age greater than 65 who are on immunosuppressive medication, pneumococcal vaccination is strongly recommended. But as you'll see, we recommend it for adults of any age because your childhood pneumococcal vaccines have run out by the time you're 18. We want to protect people at the time the risk is there. And that risk is there for our patients with rheumatic disease. When it's diagnosed, we know that's time to vaccinate, regardless of their adult age. And then we have that new indication here in Canada as well, but 18 and over, administering the recombinant zoster vaccine, highly recommended. And for patients 26 to 45, HPV recommended as a conditional as well in this population. So just really great guidance to look at that American College of Rheumatology. What is a question that has come up quite often in this patient group is things like, do I hold a dose of a medication around even a non-live vaccine? So any non-live vaccine would be safe for somebody who just got the rituximab last week, for somebody who is on adalimumab, for somebody who's on methotrexate. Any non-live vaccine, safe. But do these things impact efficacy? So for methotrexate, the only data we have is a Korean study which showed us that holding methotrexate for 2 doses after the influenza vaccine, not a week before, a week after, or 2 weeks before, all those were studied. It was the 2 doses after actually improved antibody titers. So the response was better holding it 2 doses after. When we recommend this, we don't continue to hold it if they're flaring. A flared person, highly inflammatory, is not actually responding well to vaccines either. So if you're getting a flare from holding it, you just go right back to it. But if you're able to hold the 2 doses, which the majority of people in that trial were, that's great. That trial was done without the high dose. That was the standard dose influenza shot that we don't know would the high dose make a difference in that population. It would be great to know. So any other non-live attenuated vaccines, COVID vaccination, any of our non-live vaccines, pneumococcal, whether it is the conjugate of Prevnar or the older Pneumovax, Shingrix, all of these that are non-live, they're suggesting to just continue methotrexate. And that's because we don't have specific data to say it blunts vaccine benefit. You'll find some clinicians that will say, yeah, if you can hold it a week, we might do a little better. That really becomes a judgment call. But their current guidance is to not worry about holding it other than influenza. Rituximab, different story. Again, it is really reducing these B cells that make antibodies. So it's an animal unto itself. We would say to just give rituximab, it's in the system, it's infused every 6 months. So once you give it, it's there for the next 6 months. So people with rituximab, if flu season comes up, we've got a big flare going on in terms of a COVID resurgence. At those times, you're not going to get a great B cell response, but you'll still get a T cell response. You won't make antibodies, but you will create T killer cells, and they will kill cells that virus enters. So it is still of some value to give vaccines, even though you don't get the B cell response. You're in a pandemic, you're in a moment, you just give it, and whatever you get, you get. But if we can wait till closer to that next dose at 6 months, and then give our pneumonia vaccine, our shingles vaccine, things that aren't so pertinent in the middle of a crisis or the height of a flu season, then we would wait, which is why it says then delay, give your vaccine, wait 2 weeks for it to respond, and then give your next rituximab. Other immunosuppressive treatments other than methotrexate and rituximab mentioned above, we continue. We don't delay them. Anti-TNF therapy, all the others, anti-IL-6 drugs like Actemra, you may have heard of, Kevzara, Orencia, all of these, no delay, discontinue. And I think that's helpful for us to see this updated guidance. On the next slide, prednisone. Always get the prednisone question. So under 10 milligrams a day, not immunosuppressive, you just go ahead and give whatever vaccine you need to. Between 10 and 20, we're still saying, yeah, go ahead, give your vaccinations. But if you're over 20 milligrams a day for more than 2 weeks, we would suggest that even though in a crisis, it's flu season, we got to get things shut down. We're just going to give it. COVID, we'll give it. It's not unsafe. But if we have the opportunity to delay while tapering happens and to get under that 20 milligrams, then we might be better for a vaccine like Prevnar that's lifelong to give us a little bit more time till the prednisone tapers and to give it at that time. So that's great guidance. On this next slide, you're seeing something that I had done with one of my pharmacy students. Oh my gosh, pharmacy students are a blessing. So a lovely pharmacy student that I had a few years back from the University of Waterloo. And so we wanted to create with our recommending or referring physicians, our rheumatologists that I deal with quite a bit, and also gastroenterologists, dermatologists. They wanted something that when I was doing my vaccine recommendations would show them what has the person already had, what do they plan to get at their family doctor, what things are we going to do in our clinic setting. And so we have an electronic medical record, a Curo, that we use for scheduling deliveries, for recording a lot of our counseling documentation and so on. A lot of our checklists are populated in a Curo. We still have our dispensing system separately. So this is a vaccination report, basically lets the physician know the things that we plan to do, what I'm suggesting, and they can sign it and return it at the bottom, and that then can also serve as a pharmaceutical opinion. The recommendation box, we've just blown up a little bit. So you can see for this individual, I am recommending Prevnar 20, our newest conjugate vaccine covering 20 serotypes of pneumonia. It is not yet covered by the government, but would be in the best interest of this patient to receive. Shingrix for the 2 doses, and I can do it 1 month apart. We do have new evidence for that, and a new update in the monograph this last year. So someone who's starting on rituximab, someone I need to get 2 doses in quick, I will do that because I've got that 6 weeks. I'm going to do the first dose, second dose a month later, and then 2 weeks later, she will be starting her treatment. And Tdap, always publicly funded, she'll get it from the office. So that's just sort of a good summary of a way that I quickly, with a template, had a student support, got impact from the people I'm sending it to make sure this was going to be a usable document that everyone would appreciate, and they certainly have. The next slide here, just reminding us again, a polysaccharide sugar-coated vaccine, such as Pneumovax, does not create the same kind of ability to boost. So when we give Pneumovax, we don't get as good a response that's long-term. When we give a booster of it, we don't see the B-cell, T-cell intercommunication. There's not this memory B-cell activation. And so as a result of that, when you give a booster, it's a hyporesponsiveness. You get less response than you had initially, and the Pneumovax is only lasting 5 to 8 years at most. It doesn't reduce the nasal carriage that a conjugate vaccine like Prevnar does. So that's why we really have wanted our children who can't create as good an immune response, or elderly. We know that the conjugate vaccine is much better. And now, of course, we have indication across all adult ages to give the conjugate. And with the 20, an upgrade to the 13 we've had, I was ready to, light some fireworks when that came out. They had it first in the US, and I'm like, when are we going to get it? So actually, those are the things that make me really happy. The next slide, just a snapshot here. So when we look quickly at the publicly funded immunization schedule for Ontario, you can just Google publicly funded immunization schedule, Ontario. It's that easy. It pops up with a document several pages long. And on the main page, you will see this one was updated in June of 2022. Right now, Prevnar 13 is free for people 50 and over who are compromised. Pneumovax has been free for all adults compromised for years and years. But on this chart, it shows nothing. The second item is the Prevnar 13, pneumococcal conjugate 13. There is not a star. There is nothing that tells you that age 50, or a star even at 65 to say at age 50. There's nothing. You would look at that quickly and not know that you could give that for free in a physician's office, unless you go to our next slide, which is table 3, a few pages on, which shows you the high-risk vaccine program. That's a little different. And then there we have Prevnar 13 greater than age 50. And in fine print, in this box full of the criteria that would allow a family doctor to give this vaccine out of their office supply, you've seen for immunocompromising therapy, use of long-term steroids, chemo, radiation, post-organ transplant, biologic, and certain anti-rheumatic drugs. Okay, so that's where our patient would have fit, should have had that Prevnar 13. No wonder it gets missed all the time. So this is where we're going to need to watch for to see where Prevnar 20 is going to lie. We don't have a NACI statement yet. As soon as we get that, we expect each province to make their guidance as to the coverage this will have. My hope is that we get Prevnar 20 for 18 plus who are compromised, not just 50, and that's really where it belongs. And then in our next slide here, what we're seeing is really the role that CDC, based on their guidance, we don't have NACI guidance, but in the States, they're saying just as a general statement for pneumococcal protection, everyone over 65 should have that for sure. And really 3 options. The new Prevnar 20, we have a 15-valent that is approved in Canada, but not yet marketed. So that one is Vaxneuvance. So Vaxneuvance is the PCV 15. If they do that in the States, they're recommending still that Pneumovax, the polysaccharide 23-valent 1 year later. And if you've already had that Pneumovax in the past, then 1 year later, you could upgrade with a PVC 15 or 20. So that's the American guidance right now. We haven't got the Canadian, but we've got the Prevnar 20. I am recommending it daily, and I think, Siva, you've done a ton of doses. So very exciting. And then I think this is the last one of my series, is it not, Siva? You're probably sick of me almost.
Yeah, I'm listening to it like I'm your student after all. But yeah, I think you just can talk about Evishield briefly. So.
Yeah, so the Evishield, really, what do we want to say here? I just want, you may have got a notification you can order Evishield. So in a patient like Sandra, absolutely, we know that they're not going to respond as well to future vaccinations having rituximab on board. Even if we wait the 6 months, they are going to have a suboptimal response. And so Evishield is 2 antibodies that when given by intramuscular injection are a preventative, not to replace vaccination, but an additive layer of protection to vaccination. And so this is also something that now people receiving rituximab, the anti-B cell therapy, will now be eligible to get Evishield as a secondary means of protection. And that is something pharmacies can order in, not inject. It would have to be taken. It's an intramuscular injection, 1 in each buttocks. But just want to let you know that that was only available for our cancer patients, primarily transplant patients, and just got expanded to people like Sandra. So I would be recommending that to her as well. So bad news, we've done all this. We recommended vaccine. She got up to date. We, of course, told her that as soon as it comes out, she's getting her bivalent COVID vaccine. But before that happens, Siva, she got COVID. Okay, off to you. What are we going to do?
Dear, oh dear. So, you know what? Let's start with our first polling question. I'm just going to launch it real quick. So, guys, this is a general question. We heard lots of useful information there from Carolyn. Let's get into antivirals. Are you comfortable dispensing Paxlovid just generally? Because, guys, you've got to be comfortable with us. You know Carolyn and I very well. This is completely anonymous. I talk to hundreds of pharmacists each week, and they don't want to go near a Paxlovid script. So let's go through some examples to build confidence. And I really appreciate everyone's honesty here. I'm going to, 80%, right? Thank you so much to everyone. I'm going to end the poll because we've got some really good data here and share the results. Guys, if you're not comfortable dispensing Paxlovid or semi-comfortable, I hope this gives you confidence or reassurance to know you're not alone. Do you know what I mean? We're going to go through some vignettes that I've encountered, and it's going to make you more confident. I guarantee it. So I'm going to stop sharing there. So let's get half of you more comfortable with Paxlovid. So this is my colleague, this pharmacist colleague on a Friday night, right? Real life patient, not hypothetical. You can see October 7th right there. We received this at, like every other Paxlovid script, at ungodly hours. There's no EGFR, no indication on eligibility, no date of a positive test or symptom onset, and no indication of vaccine status. So we love this, right? Totally comfortable here, no issues. You know what? COVID can go fly a kite, if I'm allowed to say that, because we've got Clinical Connect, right? We can look at the EGFR and we can get the rest of the stuff verbally if we wanted from the patient, all the other stuff. So I've got Clinical Connect and can look this up, but my pharmacist colleague didn't. So they sent this urgent, an urgent note to the physician asking them to fill out that standardized form that we all love to see. Because we really need those details to make our clinical judgment and exercise our professional discretion in dispensing Paxlovid. And not having it really does delay treatment and leaves that box of Paxlovid on the shelf outside our patient system a day longer than we would have liked to. So it's Saturday now, and I'm on shift, Saturday morning. And I see this note that my colleagues left me, and this patient is actually Karen, and she's 40 years old. I've anonymized a lot of this stuff, guys, but this is an accurate description of what happened. She's 40 years old. She has congenital heart disease. She's had 3 corrective surgeries, all in childhood. She's got a mechanical mitral prosthesis in the aortic valve. She's got excellent oral hygiene, which is important when you've got a prosthetic valve in your heart. And she's got no known drug allergies. I know her really well, and I'm very fond of her. We look at the file, right? I'm thinking, great, I've got the EGFR, and then I see warfarin on the file, right? She's on atenolol, and she's had 3 doses of COVID, which is good. And she's had her annual flu shot, which is also good, right? We know the flu shot can protect against certain cardiovascular disease risk. Now let's look at the INRs on the side, right? Those 4 recent INRs, that's September 7th, 7.7. I'm not being dramatic, but that scared the bejesus out of me. So this is me on Saturday. I was like, yeah, I've got clinical connects, but you know what? She's on warfarin, and she's very labile, very sensitive to warfarin. So let's look to the Ontario Science Table guidance document. So Dr. Kelly Grindrod and the University of Waterloo team made this document, and it's a really, really good document. I really want to take a moment to thank them, because it really told me, calm down, you know. We can, if we want, advise to monitor for signs and symptoms of increased bleeding and bruising, and to check the INR if indicated. And that yellow diamond on the side there, it's got all these sort of drug interactions, and that yellow diamond means a specialist prescriber or pharmacist might be able to guide therapeutic monitoring. So it's not an automatic no. So that being said, we've seen this warfarin patient here. Let me launch this poll for all of you guys. I'd love to know what you think. Would you dispense Paxlovid here? Because the science table document says it's not an automatic no, but considering the fact that she had an INR of 7.7 recently, would you dispense it, yes or no? No right or wrong answer here, just everyone's unique personal clinical judgment. Carolyn, would you dispense it? It's hard to say, isn't it? You can be a maybe.
I would, you know what, I really think I would say no. I'm a little scared of that level of INR. Is she going to go and get that monitoring done? Is someone going to see that result soon enough? You know, like I'm leaving things in someone else's hands, and that just makes me feel uncertain. I think, you know, look at her level of symptoms, and we have other options beyond this, right? If we need to go that route, we can refer her for other options. That's my gut, but this is a gut thing.
Carolyn was honest, and which we appreciate, and the 70% of people that answered were honest as well. So thank you guys so much as well. So, you know, some of us guys would dispense it, you know, with probably the appropriate monitoring, and a significant proportion wouldn't. So I really do. It's really good to share these kinds of opinions amongst each other, right? Because there is really no right or wrong answer, so to say. So I looked at this, the reputed Liverpool drug interaction tool, and you know what? It is a good tool, but I didn't find it this helpful here because it didn't really guide my clinical decision making. Still a great tool, but all it said to me was ritonavir is a potent inhibitor of CYP3A4. It can increase warfarin levels and affect the INR, but we kind of already know that. So not diminishing it in any way, really good tool, but didn't help me here. I get asked a lot of questions about Paxlovid, and a lot of peers that I speak to on a weekly basis saying, you know what, we dispensed this Paxlovid script, but was it really necessary for this patient based on vaccine status? So if we look at this executive officer notice here, letter E, this looks pretty all-encompassing to me. That is that in the clinical judgment of the prescriber, if a patient or individual is assessed to be at higher risk of severe COVID-19 based on their age, vaccination status, then they're eligible. Now, if you think about that science table guidance, which a lot of clinicians go to in regard to vaccination status in some areas, that data is relatively quite old. So that science table advice saying a third dose provides robust immunity, for sure it does, right? But when we're talking about antivirals, let's think about the Omicron surge. I showed you that picture initially. Carolyn got her COVID booster in December. Now think about all those vulnerable patients that were very good and got that booster in December or January even. It's now October. How much do we know about waning immunity in these patients? Not as much as we'd like to, in my opinion. And making Paxlovid appropriate is, I think it's a no-brainer in some of our more vulnerable patients. So we have to think whether we are, in some instances, informed enough to make that judgment call. There are so many patients, in my opinion, including this 40-year-old female, who's got significant history of cardiac disease that might benefit from Paxlovid. Unfortunately, the INR situation was too sensitive for me, so I referred her to St. Joe's in Hamilton to explore remdesivir options. So I didn't dispense Paxlovid here, but it just goes to the point that it might have been appropriate. So when we're deciding on antiviral treatment and who might benefit, and we're talking about vaccine status, we talked about all that waning immunity, right, which we don't really understand. Let's just remind ourselves, older adults, they have immunosenescence, right? They don't have the same immune system capacity as the rest of us. A prolonged amount of time since vaccination, so over 6 months, we know that immunity wanes. How much it wanes, I don't think we know it well enough to make that judgment call. And like Carolyn said, people on rituximab, methotrexate, adalimumab, don't know if I pronounced that correctly, so I apologize, Carolyn. We know that they would benefit for sure. So when we think about risk and total risk, as we add the total number of risk factors, the total risk gets additive. This guidance document from the National Institutes of Health in the US and the supplementary document on the right from the CDC is quite encompassing of most of the routine disease states many of us see in community primary care or hospital practice. And this guidance document, which is referenced here, affirms why Paxlovid was prescribed in this 40-year-old young patient of mine with congenital heart disease. So I'm going to be sure to make sure she gets her flu shot, which hopefully I'll get in next week. And then when I was sharing this with Carolyn, she said, "Siv, you forgot something," and I did.
Yeah, I was looking at her and I thought, okay, you got her through this, you got through the COVID. Now, all being well, you identified her as a vulnerable person, someone who would benefit from this treatment. She would benefit from other vaccines too. So I just wondered what ended up happening with that. And then what did you say?
Yeah. So, I told her, let's get the bivalent, obviously 6 months later, because you've had a COVID infection.
Yeah.
Got her a flu shot, but I forgot about pneumococcal, right? It's indicated 18 plus in certain individuals, and I forgot because she's so young in front of me, right? I just forgot.
Now, and one of the things, not in this slide, but the previous slide, Siva, where you had the red circle around point E, when we looked at who was actually eligible for Paxlovid and based on Ministry of Health guidance. And that point E that says the individuals assessed as being at higher risk of severe COVID based on their age, vaccination status, risk conditions, excluding risk due to travel by their prescriber. So I think we also need to look at this. We're not the Paxlovid police. We're there to ensure that the prescription is clinically appropriate by looking at the interactions, by looking at the timing from when they first had symptoms. But if a prescriber is electing to give Paxlovid because they feel in their judgment that there is enough risks in that individual that there is a need for this, we're not the people to really challenge that. And I have seen people turned away who had prescriptions for Paxlovid. So I think this point E is an important one. Just to throw that out there.
No, you're right. You're absolutely right. We're not the Paxlovid police. The appropriateness, it's very all-encompassing according to different guidance. So you're absolutely right.
So on this, when you were talking about who do we flag for maybe that vaccination discussion, so there's a lot of people we're going to flag. Certainly when someone's sick and has a virus, has a bacterial infection, has shingles, has whatever, there's sort of, how do we prevent other infections in the future? How do we take that conversation on Paxlovid, or the conversation when someone comes in for an antiviral for shingles, or someone comes in for an antibiotic for their chest infection? We're automatically thinking, we got to prevent this from happening in the future. We need to sort of place those reminders ahead in the system. So who should we really have flags go off on our head that we know, hey, we need to look at vaccination these people maybe earlier than we would by age alone. So everyone, pneumococcal protection age 65, that's for sure. Everyone, shingles recommendation at age 50. But we've got all those people younger than that by their condition or treatment that makes them more at risk for these things. So people on biologics, methotrexate, right? Immunosuppressive, or giving it to somebody who has an autoimmune disease. The disease itself, not just the treatment, increases risk of pneumonia, shingles, influenza in those patients. People receiving chemotherapy, like, someone's going to be getting cancer treatment. They're talking to you. You're the regular patient. They say, oh my gosh, I just got this diagnosis. I'm seen at the cancer clinic. The person who lets you know that they're on a transplant list, they're going to be compromised for life, that person. The person who's going to start cancer treatment, they're a person who's going to be at increased risk. The window for opportunity now exists to get these people up to date. People who have diabetes have increased risk of pneumonia, increased risk of shingles. Our patients who have cardiovascular disease, increased risk. So, and certainly we think about people with COPD, people with asthma. Chronic medical conditions exhaust the body, and that exhaustion leads to a decreased immune response. They are more vulnerable people, period. We really need to be, having alarms go off that trigger these discussions, that's for sure. I do like this next slide. This was a study that was done that just looked at the impact of pneumonia being associated with increased hospitalization. So hospitalization with pneumonia, because we know many people end up in hospital due to pneumonia. So that subset of people that were hospitalized with pneumonia, they had a subsequent increased risk of cardiovascular disease. And we know that. We know viruses generate an inflammatory response. We know that for sure. We've seen this as described, cytokine storm post-COVID that gets people into problems with cardiovascular risk, with lung issues. And that's why we use anti-inflammatories. In fact, IL-6 blocker like Actemra is used in ICU, not to kill a virus, to get rid of the inflammation. Well, that happens with pneumonia. That happens with influenza. But in fact, with pneumonia, the risk fourfold for cardiovascular risk in the first 30 days after pneumonia. And although it progressively declined in the first year, it remained 1.5-fold higher in subsequent years, meaning this burden for cardiovascular risk factors continues years and years after the pneumonia incidence. So when we talk about preventing infection, we're not just talking about, I'm going to be down and out for a couple of weeks. We know that 50% of people are in ICU prior to COVID due to pneumonia. And people who have never had a heart issue will have arrhythmia, will have a stroke, will have an MI. These are people who have never had a heart problem. This is unbelievable inflammation surge after these viruses. And prevention is always the way, right? It's not the after the fact.
For sure. Carol, I'm just going to mention, guys, you know what? We have got 2 more clinical vignettes, so we might go 5 or 10 minutes over because we really want to show you the reality of what's going on the ground. So forgive us for going 5 or 10 minutes over. Just thought I'd mention that.
So we next have Rahul, and he is representative of he's a competitive cricket player, but really representing our ankylosing spondylitis population. So he had 2 NSAIDs that did not, which is the criteria for advanced therapy. So he's going to be going on a JAK inhibitor, and you'll be seeing more and more of these Janus kinase inhibitors used for multiple conditions, from rheumatoid arthritis to atopic dermatitis. It is just spreading. It'll be coming out for alopecia at some point, but we know it is now approved for AS, this particular JAK inhibitor, which is called upadacitinib, known as Rinvoq. It has an increased risk of shingles greater than our other disease-modifying treatments. So yes, he's a young person, but he has an autoimmune condition. He's going on a treatment that makes that risk even greater. So when I think about his medication history, and if I asked him, are you up to date? He's going to say yes, because he's had his COVID vaccines ×3. He's waiting for the bivalent. He had influenza annually, had it last year. Yes, his tetanus, yeah, it's out of date. He needs to get a new one of those. Hep B done, meningococcal, he got both the B and the quadrivalent going to university. I mean, he's on the ball, got his Gardasil. Everything is awesome, except he is got an autoimmune disease, and he's starting on a treatment that increases shingles risk. So I am going to recommend the Shingrix ×2 doses, because it is now approved for everyone 18 and over who is at increased risk, either by disease or by treatment. I'm going to recommend Prevnar 20. His Prevnar 13 that he would have received in childhood has run out. He needs that upgrade. He is a person of increased risk. And of course, that tetanus shot at 10 years has now gone, so has expired. Just letting you know about this public funding situation in our next slide. This is a snapshot just of herpes zoster coverage. And I put this up there so you can see it's not the same across the province. And even some of our national programs are different. But what I wanted to draw your attention to in particular is in PEI, Shingrix is only available as a publicly funded vaccine through pharmacies, not even through the family physician's office, only through pharmacies. I am very hopeful that we can negotiate with Prevnar 20 just being released this summer, that we could make it and other publicly funded vaccines available in pharmacies for greater access. And it's my hope that we make that vaccine 18 plus. But I just want to give you a sense to keep looking back at the funding models, because they will change over time, and we need that NACI guidance in order to see what each province is going to do. So what if a vaccine isn't paid for? Somebody wants Prevnar 20, like I mentioned with Sandra. I really wanted her to have it. 20 serotypes, my gosh. But only the 13 currently would be covered, over 50 compromised. So what if I wanted her to have, Shingrix as mentioned, and it's not covered until 65 to 70 with this catch up now for the next couple of years for birth year 49, 50, and 51. But what if she isn't eligible for a vaccine I'm recommending through public funding? What if she doesn't have a private plan? We really need to push these long-term sequelae of people not getting vaccination and actually getting the illness. It really has a burden. It has a financial burden. It has a health burden. People have health spending accounts they need to look at. But you know what? At the same time, we also have to think about people saving for the next several months, putting money aside, asking people for a vaccine as a birthday gift, as a Christmas gift. I have these discussions with patients. I also will extend them the courtesy to say, if you want that vaccine now and you can't afford that $140 or that $200 or whatever it may be, you know what? I want you to have the vaccine today. Let's set up a monthly payment plan and get their visa. And we have an agreement. I get them to sign something, and they're vaccinating today, but I actually have them pay sequentially, especially if I know they're starting a treatment that compromises them. So that certainly is, something that's a policy within your own setting. I'm just saying, we have to be creative to make sure people get the support that they need.
That monthly payment plan, Carol, I would never have thought of that. So that you've kind of overcome, like, you made me open my eyes a lot more. That's something I would never have thought of in my practicing, and it looks feasible. I just wanted to, I know we skipped over this slide, guys, this thing that Carolyn did in Akiro, if you're working in primary care, I hope it gives you some idea about operationalizing it to make sure the physician colleague that you work with sees it, actions it, and makes sure that your patients are practically protected against vaccine preventable disease. I think that's excellent what she's developed with her pharmacy student there. So another clinical vignette here. Paxlovid script at ungodly hours again, 9:10 p.m. Love it, right?
It's always the night before a weekend, Siva. This is when there's a hospital discharge. This is when these things happen, and you just want to hide, but you can't.
I don't blame peers for not wanting to touch certain things, because it's hard sometimes, right? There was a comment in the chat group about amiodarone. Patient has amiodarone. They weren't comfortable dispensing Paxlovid. That's okay. You know what? Look at the guidance document. Make your own clinical judgment. Just know how to refer. Know where to refer in your local area. So with this script here from the local emergency department, again, you can see it was received on the 7th of October at 9:10. No EGFR, no indication of eligibility, no date of a positive test or date of symptom onset, and no indication of vaccine status, right? So as pharmacists always do, we just get on with it. We smile, reassure the patient, think in our head, fudge, right? We wish we had all this stuff on the script so we could guide our clinical decision making and dispense this prescription the way we'd like to do. So I think that describes a lot of us. So as you can see, my colleague, my pharmacist colleague on shift faxes the physician, and they say, dear doctor, please fill out this standardized Paxlovid form that can encompass all the information we need to help this patient as a pharmacy team. So guys, this is a frequently asked question. Like I said, I speak to so many pharmacists on a weekly basis. If you had an EGFR, so if you had their kidney function taken in the last 12 months, would you proceed with verbal confirmations for all the other necessary clinical information? Again, no right or wrong answer here, guys. But if you've had a kidney function done in the last 12 months, if you think, oh, last 12 months isn't recent enough for me, I want it done more recent, then hit no. or, but yeah, would you dispense it if you've had one done, and you can confirm everything else verbally? Guys, I really do thank everyone for being so interactive. We're already at 50%. And in the interest of time, I'm just going to, 70%, just like that. So I'll end the poll just there, and I'll share the results with you guys. So guys, again, I hope this gives anyone who hit yes, no, or I need more time to think about it, reassurance, right? You're not alone, right? There's a significant proportion that will do either one. And again, this is about your professional judgment. So I'm actually happy with an EGFR in the last 12 months with a lot of my patients, especially if they, they didn't show any signs of decline, or if they were on the higher end of what we need to know about. If they're on those thresholds for dose adjustment, I might insist on a more recent EGFR, but I'm pretty happy if there's one in the last year that I'm satisfied with. So it's Saturday morning and I'm on shift, right? And we get this form back, eligibility check, date of positive result check, date of symptom onset check. No EGFR, the space was actually left blank. 79 mils a minute is something I've added in there. And their name and personal details are blank, which I can live with, I can fill that out. But that EGFR, if I wasn't on shift and I couldn't look it up, what would happen, right? So this is an accurate depiction of me, without my tan, of course, right? Calling the emergency department to catch that physician colleague before he calls it a night, right? Having worked a 12-hour shift. So get on the phone with the receptionist, and very nice receptionist, by the way. Before I can get a word in edgeways, can you fax it, please? So I'm like, okay, what's your name? My name's Peter, not real name. Have to anonymize everything here. Thank you so much, Peter. I'm just going to document your name here and the time of the call so I can document who I spoke to regarding this patient. I'm really sorry. This is something I really have to talk to. Let's call this doctor Dr. Friend, right? I really need to speak to Dr. Friend as soon as possible. Please put me through. So they put me through to Dr. Friend. Hi, Dr. Friend. How are you? I'm okay. Hope you had a decent, uneventful shift. Thank you so much for sending this form back. And again, guys, you guys can empathize with me. Prefacing any question with "in the future," it's tough to ask without it sounding demeaning, right, to a colleague. So I'm hoping this isn't the physician on the other side of the phone. And I asked in the kindest way possible, in the future, is it possible to put the renal function on the script? He says, look, Siv, I've had 2 MIs, a TIA, and a car accident tonight. That might be hard. And he said it super respectfully. So I said respectfully, no worries at all, totally understand, but missing this stuff can delay treatment because I know a lot of colleagues, pharmacist colleagues, that won't feel comfortable dispensing Paxlovid without the information they need, especially renal function. So, just letting you know that it'd be really helpful that if you fax a script to put that on there. And I said, consider using your support staff if possible to put that information on the script. I understand you're busy. And so it's a very respectful conversation, and I honestly empathize with how tough it is for pharmacist colleagues, physician colleagues, and nursing colleagues in emergency rooms around the province and the country. They're very short-staffed, and they're working under tremendous pressure. Let's take a step back before we take a step forward. Let's look more closely at my patient, John Maurice here. He transferred into me recently, coming into Ontario in February. He's got depression, diabetes, hypertension. He's had a stroke in the last 5 years. He can't remember exactly when it was, but he's got left-sided weakness because of it. And he's 70 years old, which is also important here. You can see a brief snapshot of his drug and vaccine history there, because we dispense some vaccines, right? So this patient's new to our pharmacy, so just gonna check time here, 7:52, so we're doing all right. My colleagues and I, we always like to do a meds check with anyone transferring in. So whether it's an annual or a follow-up, if a patient's already had an annual, we'll do a follow-up. And the reason is a thorough medication reconciliation can be so helpful and is so conducive to medication safety. So we did a diabetes annual here because he moved from Atlantic Canada. And we've got the following lab information here. His A1C is elevated at 10.5%, EGFR is 86, LDL is 1.97, and the following functional information as well. He's got functional weakness, a high degree of frailty, high risk of falls and frequent dizziness. I got some of this from Clinical Connect, but I got some of this from the history too. So if there's one thing I ask all of you on this call is at least do your own assessment of where your patient might fall on this frailty scale. And I use this to really contextualize risk and benefits of targets, hypertension targets, A1C targets, the potential benefits of therapies, and this includes vaccines, right? So I estimate John Maurice here to, in my mind, sit on the 5 on this scale. someone living with mild frailty, evidence slowing and weakness from his stroke, needs help with his housework, meal preparation, meds, etc. He's not bedbound. He's moved in with his sibling and now is able to help, and now can help him continue to live at home with a reasonable quality of life. A bout of COVID can kick him down permanently to a 7, where he's completely dependent on personal social care for the rest of his life. So let's think about that. When we think about influenza, pneumonia, or COVID-19, a bout of either of those can kick our patients down permanently. So let's look at flu here, for example. So we've got 2 studies here. The flu study, which we talk about first, influenza was observed to cause a decline in major physical functions in a significant number of survivors. Peers, don't forget how the flu shot has an incredible utility in protecting your patients from severe disease and disability. When it comes to pneumonia, let's look at this other study here. So this is looking at patients that develop severe disability within a 1-year period. And pneumonia was up there with stroke, hip fracture, and CHF in the principal discharge diagnosis associated with those disabilities. So we've got vaccines that prevent against pneumococcal pneumonia. Let's think about that, and let's be mindful of that when we're recommending things that can help John Maurice here. So again,
I absolutely love that point, that frailty point, because when we think about frailty getting worse, it impacts longevity, right? It's one of the biggest measures of longevity. So seeing that person in front of you, they can't take one more hit. Yeah, and prevention is always better than the treatment after the fact, right?
Thank you for affirming that, Carol. You know, I'm not pretending that we're social workers here or nurses to know exactly where they lie on it, but it's really important to contextualize. I really appreciate you saying that. Mm-hmm. So again, we're determining risk. We're talking about the frailty scale. We did a med review. After this med review, we agreed that Prevnar 13 at the time, because let's remember this is February, Shingrix and the 4th COVID shot at the time, there was no bivalent, would really benefit Jean Maurice and give him tremendous significant clinical utility. So optimizing the Ozempic dose here to 1 milligram pretty much eliminated postprandial spikes, and we were able to adjust his basal insulin right down to get his A1C to 6.6%. 3 follow-up med reviews, as you can see in the top right there, in that first week of the Ozempic dose change to check in on hypoglycemia and invite him in for those first few vaccines was really important. So, see, I'm not missing anything on this slide. No, that's great. So again, Piers, I'm super cognizant of this frailty scale, like Carolyn said, when doing much of my work with vaccines or diabetes management. So now it's October, Carolyn, and in the near future, he might benefit from Prevnar 20, right?
Absolutely. And I mean, I think we have to look at the fact that someone had Prevnar 13 and you had on his profile. When did he get that? We just go back, you had
April 2013.
Beg your pardon?
April 2022, sorry. April 13th, 2022.
Yeah, so we're really looking, I mean, for the data that we looked, there was a trial that looked at people who had Prevnar 13, followed by Pneumovax a year later, just the Prevnar, just the Pneumovax. It didn't matter what combination or what they had. They all did as well in terms of the increased protection Prevnar 20 gave with the additional serotypes. They didn't have any worse outcomes, vaccination reactions, because they've had past vaccines. And so when they were looking at that data and the robustness of it, they based people going from a Prevnar 13 in that trial who were then going to get a 20, it was a 6-month spread. So based on that, we're suggesting if someone's had Prevnar 13 and now wants to upgrade to the additional serotypes, that they would wait 6 months. So he certainly is going to be in good shape to get that. We see here on the pneumococcal vaccine serotype overview, we've got that chart up there now. So we have the Prevnar 13, the 15, the one that is approved but not yet available, which is Vaxneuvance. I don't think we're going to see much of that because we have the 20 available and we're going to get more protection from it. So these are all, again, non-live vaccines. And then the last one, of course, is our not conjugate, which the first 3, the last one is our polysaccharide Pneumovax. So although it covers 23 serotypes, you may say, well, that's great, that's better, but again, not as with the robustness, not with the duration. And that's what really moves us to doing our happy dance when we have Prevnar 20 giving us that lifelong protection against more strains. We have to also look at why they picked the strains they did. So when Prevnar 20 was developed, it was looking at sort of the international level of bacterial pneumococcal strains and their prevalence, what was the most dominant sort of worldwide, and what had the highest rates of antimicrobial resistance, what were we seeing as really being the dominant strains that took people into hospital. All those things were considered in picking that 20. Now, we have it out on the market. Of course, Canadian data may be a little different than that internationally, but we still see within Canada really great protection across many of these strains. So you can see in the green bar, these are the types in Canada that were causing most of our pneumonia, pneumococcal disease, invasive pneumococcal disease. And so you can see that the majority of those, other than the 9N strain on the far right, were all covered by Prevnar 20. The ones with the highest resistance, so this is important. We get them, but we don't have something that can treat them. We're covering all of those with Prevnar 20, the ones with highest resistance. So that's really a key. And then predominant vaccine preventable serotypes in the hospitalized individuals, so the ones that took people to hospital. Again, we've got great coverage with Prevnar 20. The only one that we don't have there is the 9N. The 9N didn't seem to be as much an issue, I don't believe, internationally. So that's probably why that's not in there. But you see the CDC looking at Prevnar 20 and putting it right there as an option alone, without even the Pneumovax, as we looked at as a CDC guidance. So I'd be interested to see what we're going to see from NACI based on this, but it is quite an exciting opportunity for people. I think you've given lots of those shots already, have you not?
Yeah, I've done tons of it, and tons of instances where we've had to change it from 13 to 20 because a lot of the physician software doesn't have 20 in the system. It does now. I know Practice Solutions does because I've seen it in there. But yeah, I've had to change a lot of those. So no, you're absolutely right, guys. It is 8 o'clock. We've just got a few more slides here, and we've got some Q&A after as well. If you have to leave, that's totally okay. It's being recorded, but please don't forget to do the evaluation at the end. It's very helpful for OPA to think about what to develop in the future and what's most useful for you guys.
Did you want to quickly look at that bar graph, Siva?
This one, eh? Is this the one, dude?
Yeah, I'm following my own slides here that I've got memorized because I never got them showing up on mine. So I think I'm doing pretty well. You're
doing awesome, mate. Love it. I've got it up now, mate. The mortality increases with the discharge, right?
So no, I'm just talking about the after the one that we just did, showing the 3 different circles, and we have our bar graph.
Oh yeah.
After that, so I didn't know if you wanted to just highlight those differences.
Yeah, for sure. Yeah. So again, guys, Prevnar 20, you can see those different colored bars there, and you can see the additional protection afforded by doing 20. And when we think about that severe disease as well, this is why it's important. Even if they've had Prevnar 13 before, it's good, and we've told them it was once in a lifetime, but things have changed, and I think it's definitely worth it, particularly in our most vulnerable patients, for sure.
Okay, so the mortality increases in the year post-discharge. There's the other piece with pneumonia. It's not just the fact that it was bad enough to get them to hospital. Even if they survive it and they're discharged, we have this year post with many aspects. We've talked about frailty, but here we are, mortality. So we're talking about death during hospitalization, 3.5%. The 30 days from admission post-discharge, 8.2%. But from admission to 1 year, look at that rate, 17.7%. We need to prevent it. And the sad thing, when my mother-in-law, and some of you have heard the story, was admitted with pneumonia, she was frail. She was not able to do things the same afterwards. I can't believe she even got out of ICU. But this is a woman who, she had arrhythmia. She was doing, so unwell. She was in ICU for 4 weeks. And I asked, do you recommend for patients with pneumonia in hospital that they get their pneumococcal vaccination once they're feeling well and home? Do you get them knowing the risk that they've just had? Are we at least going to protect them from the future? And you know what? It was a no. There was no work done at the end as part of discharge, not when they left ICU, not when they left the hospital at all. So I really think across the board, there's a lot of touch points we need to be making.
Your mother-in-law had osteoporosis too, which is she had just so many risk factors, right?
She did. And so when you have an osteoporotic fracture, that increases your risk of pneumonia significantly. That's why there's such a high rate of death in the year following an osteoporotic fracture. It's different than a fracture in healthy bone. It puts the body under undue stress, and that risk of pneumonia is high. And I said to her, you know, I'm really worried now that you've had this fracture that, you know, you're going to get pneumonia. And I hate to say, she had the fracture in May and she was in ICU in September, and she refused to get the vaccine. After that, the family basically tied her down. She agreed to it. But you know what? It was a shame. It was just such a shame.
Almost a death sentence, like you said. I'm going to skip this slide because it talks about frailty, and we discussed it at length here. This is an important slide, though, guys. So up until the end of September, only just under half of eligible patients completed their third dose. That green cross in the top corner, it really symbolizes how important pharmacy is as a provider of healthcare, and in this case, vaccinations. We play such an important role in access, and therefore a mechanism in reducing hospitalizations, death, and other complications that Carolyn and I talked about. And then, you know, we come to this slide here. So obviously, Carolyn and I from Hamilton, we do a lot of work in Hamilton. We look in the top right there. That's the front page of the spec when the first lockdown was declared and how terrified everyone was, including us. And then we look at that green cross again. When others couldn't be there, we were there as an essential and critical service to the public. And I think it's really important to be mindful of that. I'm not trying to be cliche or dramatic here, but it's really important to remember that green cross and think how important it is to make sure we have enough Paxlovid in stock in the coming winter months. How many times have we got a script for Tamiflu for a kid or someone vulnerable, look to the shelf when we don't have any in stock? You know, it's happened to me a couple of times and we feel great regret, right? Because the window's going to go, no one else has it in stock. It's really important to be mindful of that where possible to ensure we have it for our patients when they might need it.
And especially the Paxlovid renal, right, which hasn't been out as long. You want to make sure you've got that on hand as well.
Sure. I ran out yesterday after I dispensed one. So again, shame on me. Like, we can order it in. There's such a plentiful supply. And you know what? We closed the gap, guys. We wouldn't be at the stage we are now in the pandemic without pharmacy, community pharmacy, hospital pharmacy. We wouldn't have delivered this many vaccinations. We wouldn't have got as much Paxlovid out as we would have liked to without community pharmacy. I think more needs to be done to improve access, but we've done a lot and we continue to close that gap. These are some best practices. You know, we saw Carolyn's example there about dispensing software. I think that's just excellent. Nothing falls through the cracks with what she does in her practice setting with the number of doctors that she works with. You can run reports in your pharmacy system to identify eligible patients. You know, in my software, we can see how many patients have a refill on their Shingrix. They obviously haven't completed their series. Meds checks is an important mechanism we talked about. Vaccine recommendations at meds check follow-up. So a diabetes annual, if you can't discuss everything in that first diabetes visit, it's not intended for you to spend an hour with them, right? The follow-up med review is intended for that purpose. You saw that one example where I followed up 3 times in the space of a week. And you know what? We get paid to do it because the government wants us to use the diabetes meds check to further that care for our diabetes patients.
And really, any meds check you do, the vaccines could be part of a follow-up meds check the next week.
Absolutely. I totally agree. And then you talked about herpes zoster there.
And that was just basically the reminder, if someone gets shingled a year later, they should definitely be vaccinated. And we sometimes forget to put that reminder. But it really behooves us to look at the person who's had Paxlovid, the person who has an antibiotic for pneumonia, right? And we need to put reminders. Let's check in with them a couple months later and see, okay, where you're at, right? So you can have your next COVID booster 3 months after that incident. Let's book you for the pneumonia vaccine. Like, we've got to take these opportunities and really elevate, you know, that light bulb going off.
You know, a lot of my colleagues, Carolyn, because it's funny you say that, I just want to share it with the guys on the call who work in primary care. So primary care pharmacists, they pretty much have a similar job to you, although you specialize in rheumatology. They'll book the appointment on the spot for that follow-up. They make sure that patient gets the vaccine. So you're absolutely right. There's so much automation that's there to help us as a tool to ensure that our patients are protected. Make sure you use them, guys. You know what I mean? Especially for completing a series or even booking a COVID vaccine. Guys, I've seen so many vulnerable patients I wanted to share with you. They haven't had their third dose and they're not anti-vax. They just find it hard to book. I'm not kidding you. Well over half of the patients that I've encountered, they want they want a COVID booster, a third or a fourth dose, and that's the only barrier. So that's helped them. And let's think about other strategies too. So that's the end of our presentation. We just went a little bit over, but I hope everyone found it really practical. I was listening attentively there to Carolyn because she's such a good teacher, isn't it? So yeah, love it. So let's get to some questions.
I just wanted to say, so the one thing about the online booking for both influenza and COVID vaccines, a lot of pharmacies, both independent and chains, have set up a section to ask what other vaccinations someone has already had. And they're asking about pneumococcal, they're asking about shingles, they may be asking about Hep A, B, other things. But are they taking that information as part of that intake to then look at booking them? Are they asking, are you requesting updates of these? Because the more vaccines we can do at once, the better. There's no issue with doing more than one vaccine at a time. We've eliminated the wait between a COVID vaccine and other vaccines. COVID and flu can be done together, as we know, COVID and pneumonia, COVID and shingles. You can do all these things together. And just a reminder, some people were afraid, oh my gosh, I won't bother with that second dose I missed, or the third dose of Twinrix, or the second dose of Shingrix, because they thought they'd have to get both of them. We never need to repeat a series, right? So if somebody misses a dose, you never have to repeat it. You just pick up where you're left off, whether it's 1 year later, 5 years later, 10 years later, you just pick up where you left off. I think that's important.
Yeah, I think so too. And, I kind of learned that from you like a year and a half ago. I was very hesitant on that point. Twinrix, Shingrix, it's well over what was in the monograph, but you know what, NACI is very clear. And I think pharmacists like me, we like to hear it from people like you who've got expertise in that. You never really have to complete the series. Guys, you know what? So there's a good question here. So if someone's had Prevnar 15, sorry, I think they mean Vaxneuvance, and no Pneumovax, should they get Prevnar 20 or just Pneumovax? So the current CDC guidance is just to get Pneumovax, but it's a good question. I don't think it's been studied that well. If they've got Vaxneuvance, in this current climate, I can't even order it from McKesson. When I tried to order it, I can't get that 15 valent conjugate. But so I guess we really need to be proactive and discuss that with our patients, right, Carolyn?
Yeah, I mean, right now we can get 20, we can't get 15. So I would be doing the 20, obviously. Why not get more serotype protection? That only makes sense. The studies that were done with 20 did not look at someone with a past 15. They looked at people who had had Prevnar in the past, Prevnar Pneumovax or Pneumovax. They looked at those kinds of standard things that people have been doing. And so we have data to say in the people who did the Prevnar 13 in the past, it was 6 months later, they got their 20, and that we know there was a great response. Because sometimes you give a booster too soon, as we saw even with the COVID vaccinations. It was better when people waited that little longer, right? It wasn't always the best thing to give it just because we could give it sooner. And so the fact that at the beginning we sort of delayed some vaccines to get more people first dose probably ended up giving us better protection in the long run, although we were all worried at the time. So a booster too soon is not a good thing. So I would think it would need to be at least 6 months if you wanted to go from 15 to 20, but we don't know for sure. It certainly, we wouldn't think of it as a panic, but people often want to have the best, right? They want to upgrade, and I think it should be on their radar, that's for sure.
For sure.
Because the Pneumovax, just giving it, as CDC recommended, you're only going to get 5 to 8 years at max. It won't be as a good protection against those remaining serotypes. And when you boost down the road, it's not going to work as well. So to me, that's not the long-term strategy.
For sure. I totally agree with you. And guys, I know it's 8:12 now. So if you do have to leave, totally okay. I hope you had a good webinar. Just don't forget to do the evaluation. It's really, really important to determine what would be the best programs for you in the future. So don't forget to do that evaluation. If you were live, I'd say you can't have your food until you do the evaluation, but please do it. So there you go. There's another question here. So if you have a prescription for Paxlovid for a patient with full vaccination, under 60, no comorbidities, would you question the physician about why this is being prescribed? So do you want to answer that first, or shall I answer it first, Carolyn?
Yeah, I think you can go first.
Okay. So, I wouldn't question it, because like I said before, I'm not sure what position we're in to determine that kind of risk. So say that the patient's 55, and like I said before, a lot of my patients were so proactive. They got their booster like Carolyn did in December. How much do we know about waning immunity? We know for sure after 6 months it wanes significantly, but it's 10 or 11 months now. How much has it waned over and above that 6 month period, it hasn't been studied, right? And considering that they're over 50 and they've got no comorbidities, their renal function's okay, does it hurt them to take Paxlovid? Does it? I don't think so. So I would dispense it. I wouldn't question the physician there. And that's my.
I would do the same. I mean, that's what that category E was all about. So we don't know what history this person had. Maybe they've had infections in the past that were very difficult. Perhaps they don't have ongoing asthma, but they get an infection, it really affects their lung and their airway. Maybe they're a person who can't afford to take, more than a day off because they're feeding their family and they don't have any sick days left. And so anything that's going to allow that person to thrive and support their family, like maybe that's just not disease risk, but it's a judgment made on the entire person's environment. Socioeconomic status also impacts outcomes, right? So there's a lot of pieces here that might be beyond what we have on our record. So if it's being ordered and the criteria is clear, I don't feel like I'm, again, the Paxlovid police. It's not that we are in short supply of this. We have lots. In fact, we're probably underutilizing it.
We are, yeah. We've got lots of it. It's just going to expire if we don't use it. Yeah, guys, I just wanted to thank you all so much again for answering the polling questions. I think we all realize, what our different comfort levels are with Paxlovid. And then it goes into the next question. Bivalent, so Spikevax versus the new BA4, BA5 bivalent vaccine. So guys, really good question there. Nasi says, both are either one is recommended right now, and it's a lot more important to target Omicron than necessarily some of those variants. That's the important determinant. I don't know if you've got any comments on that, Carolyn.
Well, I think, what we always say, what's available to you get, because who knows down the road what other Omicron variants will develop. And there may be a subtype that's closer to the B1 or subtypes that are closer to the B4, B5. Like, we're just not sure where these things are going to land. So we're thrilled that we have something giving us better protection than we had before. Certainly with the circulating variants today, I would think there would probably be an edge, certainly, in getting the protection that's closer aligned. But that doesn't mean that's what's going to be there next month or the month after. So I don't think we should not be giving people, either of them truly, because we just don't know where the future lies. But our protection certainly will be greater. And keep in mind, we could talk about the difference between being laid up a couple of days, a few more symptoms, versus the hospitalization and death. That's what we're always talking about, the prevention of. So I think when Nasi's saying that they're equivalent, they're saying they're both good options for preventing the serious sequelae of disease. And that's what we talk about for influenza. It doesn't mean you won't get the flu, right? It doesn't mean you won't get shingles if you get Shingrix. We're talking about severity of disease and people who are able to continue and not have impacts that last lifelong. So that's where it is. So I think there'll be people who certainly want our newer option by Pfizer that allows us a closer match right now. But and I don't disagree that people are going to want that. I'm just saying I think that it's just going to change, and who knows where we're going to be in 2 months or 3 months as well, right? Like, it's just
definitely. I really appreciate, Carolyn, you and I talked about this at length when we were preparing for this. So this question here: if a patient received Prevnar 20, would you still boost with pneumococcal 23 8 weeks later? I still would, even though the CDC says you don't need to, because I don't see any harm. What do you think, Carolyn?
Well, I think that we always talk about vaccination for today. So even though that Pneumovax is only going to last 5 to 8 years, and if I do it again, I'm not going to get much out of it. If I have a person sitting in front of me that really does have high risk, regardless of their age, they have high risk because maybe they have a few comorbidities, which is really additive to that risk. So they have COPD, they have chronic kidney disease, they're on immunosuppressive therapy. Like, there may be a few factors. And I want them to get that 9N, that one strain that was missing out of the 20 that could be, a player in hospitalization. It's not going to hurt me to give it. It certainly won't. We just don't know what's going to end up being publicly funded and how that's all going to roll out, but it's not going to be harmful. So if today I want that little extra protection, why not? But to keep repeating the Pneumovax every 5 to 8 years, it's going to be a moot point. You're not going to get much out of it. So even though the risk may be greater with age, because age alone increases risk, we always talk about vaccinate for the person in front of you, right? That's, if the risk is there today, then protect them for today.
Thank you so much. Guys, you know what? We could talk forever about COVID, and we had to cut a lot of stuff out of here. We would have liked to talk about other stuff, but we really wanted to just make it practical, talk about real life patients and not talk about hypothetical. So I hope everyone found it useful. Always love listening to Carolyn. So thank you so much, Carolyn.
Well, it's been just an honor, I think, for both of us to be asked to be part of this series, this 10 years sort of 10 years as immunizers. My gosh, like it's just been such a privilege to offer that level of care to patients and be such an integral role of people's wellness. And I think it's garnered a lot of awareness in the public and the role that pharmacists play in a broader capacity, not just for vaccinations. So as much as we're all exhausted from it, it certainly has been a privilege. And it goes back to the root of why we became pharmacists, right? Is to protect the public, provide as professionals. So I'm just thrilled that OPA invited both of us to share in this sort of celebration, if you will, at the 10 years.
Well, thank you both so much for such a wonderful presentation. Really enjoyed all those examples. I think that is so useful. And you can really tell how passionate you both are and how much you care about what you do. So we really appreciate you putting so much work into the presentation.
You're so welcome. And we pat each other on the back because Siva is just such a vaccine champion in the community. And it's always an honor to work together. And thank you so much, everyone listening in, getting late. We appreciate it.
Any final words for our guests tonight?
Let's continue the great work we've done. And I think it's going to be a tough winter season, but hopefully we can get through it with all the great work that everyone here does. That's all.
And I just like to say, use your team. You know what? How am I able to do great things, Siva do great things, is because the work that we do, our team believes in it. Our staff believes in it. So they know when I'm spending a little extra time on something or sending that report, or you have to build that pharmaceutical opinion in order to, get some income from all the work you're doing. Someone's there doing it. Someone's helping. Someone's noticing those things. And your team is supporting you because they know you're going to offer that same care to their best friend or their parent when they walk through the door. And that kind of team bonding over care and strategies that you work on together is, to me, the most valuable thing. So I hope you take some pearls away to work together to just improve all the great things we're already doing.
Okay, great. All right. Thank you all so much for joining us this evening. Everybody have a good night.
Okay. Thank you.
Bye.
Bye-bye.